Supramalleolar Osteotomy for asymmetric ankle osteoarthritis. Diagnosis. We present the case of a 28-year-old male with lateral cystic asymmetric ankle osteoarthritis on the left side. He has a background history of retrograde drilling of the osteochondral lesion of the lateral talus, a medial sliding calcaneal osteotomy, and osteochondral surgery of the lateral talus. The tibio-talar tilt angle was 7 degrees. In this case, we will perform a supramalleolar osteotomy and reposition with an anatomical medial tibial plate. Therefore, the treatment goal is to perform a medial closing wedge supramalleolar osteotomy to reduce load on the arthritic lateral angle. Anatomical landmarks and approach. Anatomical landmarks are the medial malleolus, anteromedial ankle joint line, anteromedial and posteromedial edges of the tibia. The 5 cm incision is centered over the medial distal tibia, through the skin and subcutaneous fat. Structures at risk during superficial dissection, including the saphenous vein and nerve, are identified and gently retracted anteriorly with a Langenbeck retractor. A sharp incision of the medial distal tibial periosteum is performed in line with the incision. The saphenous bundle can be easily seen. At the level of the tibial supramalleolar flattening, the periosteal flaps are elevated with sharp dissections. A periosteal elevator is used to ensure access to the tibial cortices. Homan retractors are then inserted to protect structures anteriorly and posteriorly, such as the posterior tibial neurovascular bundle. The osteotomy. 2 K-wires are inserted as guide wires at the area of the tibial flattening for the direction of the osteotomy and measuring the size of the wedge. In the image intensifier, both K-wires are seen. The proximal K-wire is perpendicular to the tibial axis, and the second K-wire is roughly parallel to the ankle joint. Ideally, the placement of the osteotomy apex is at the level of the fibular notch. A slight overcorrection by 1 to 2 degrees is recommended to deload the lateral ankle. An oscillating saw is used to perform the osteotomy along the K-wires, keeping the sagittal alignment of the cuts perpendicular to the anterior tibia with care to avoid penetration through the far cortex. The bone wedge is removed, and osteotomes are used to complete the anterior and posterior parts of the osteotomy. The osteotomy is then closed medially, hinging on the intact lateral cortex. On the image intensifier, the foot osteotomy preparation is seen. Mypotunnel preparation and plate fixation. The mypotunnel instrument is used to create space under the soft tissue for insertion of the proximal shaft of the plate. The plate has multiple distal 2.8 and 3.5 locking screw holes. The plate has 1 oblong hole, 1 eccentric hole for compression, and 3.5 locking screw holes in the shaft. The plate is inserted with a plate holder into position. It is then provisionally fixed with an olive K-wire distally. A K-wire compression forceps is used with 2 K-wires placed anteriorly to achieve compression and then checked on the image intensifier. The 2 parallel K-wires in the forceps also help to avoid any possible malrotation of the distal tibia part. The plate is centralized on the shaft and a second olive K-wire is inserted to provisionally fix the plate proximally. Locking drill guides are used to drill all the distal locking screws, which are measured and then inserted under power. The final TriLock locking is performed by hand. The most distal 3.5 screws are drilled unicortically. Distal 2.8 TriLock screws help to adapt the plate to the bony anatomy. The oblong compression hole is used to obtain compression using a non-locking cortical screw drilled eccentrically using the appropriate drill guide. A second 3.5 cortical screw in the oblong hole helps to adapt the plate to the bony anatomy. A locking drill guide is used to fill the rest of the screw holes in the shaft with locking screws, which are inserted under power. And TriLock locking completed by hand. Here the final placement of the plate can be seen. Final X-rays confirm the plate and screw placement, demonstrating excellent compression and axis realignment achieved. Closure. Closure is performed in layers with Vicryl and Prolene. Post-operative care. A walker boot is used for 8 weeks, commencing with 15 kilograms weight bearing for the first 6 weeks, followed by 50% weight bearing for a further 2 weeks. Unrestricted weight bearing is then tolerated thereafter. Early physiotherapy is focused on swelling control and range of motion. Vitamin D3 supplementation is recommended. The 3-month post-operative X-rays show a healed osteotomy with a successful deload of the lateral arthritic ankle.